I'm John Hurst. I'm a doctor and I'm a lung specialist, consultant respiratory physician working at the Royal Free Hospital here in Camden. Although, as you know, we work very closely in Camden, so I've got very close links with the Camden Community Services who put together these series of recordings. We're working in Camden now for about 12 years, from Lancashire originally, as you might be able to detect from my accent, and I went to medical school in Scotland, but London's my home now really, so I'm pleased to be talking to you today. So maybe we should start by thinking about some terminology, some of the names that we use for these different lung conditions, because it gets quite confusing. We could think about COPD, chronic obstructive pulmonary disease. We could think about chronic bronchitis, and we could think about emphysema. And these are overlapping terms. And the terms are quite difficult. You know, if you go out onto the streets here in Camden and say you have diabetes, I think people in general have an idea what you mean. It's something to do with sugar in the blood. You go out on the streets here in Camden and say you have COPD, I don't think anybody knows what that means. So the terminology itself is part of the problem. Fundamentally, COPD, chronic bronchitis and emphysema are all manifestations in the lung of being exposed to something potentially harmful. Usually cigarette smoke, but not always. And it's not enough just to have that exposure. There has to be something about you, the person, the way that you're put together. In other words, something genetic that has made you susceptible to whatever it is that you've breathed in. Now, if you think about the structure of the lung and the airway, starting from the mouth and the nose, moving through into the main air pipe, the trachea, and then smaller and smaller and smaller and smaller airways until we get right to the edge of the lung, the bit of the lung that is responsible for oxygen and carbon dioxide exchange, the sacs, they're called alveoli. These terms, bronchitis and COPD and emphysema, when we use them in their strictest sense, are referring to different parts of the respiratory tract being affected. So if it's the bigger airways that are affected, the trachea, the next one down, the one after that, and they become irritated, when they're irritated they produce lots of mucus and phlegm, and that causes cough, and the name for that is chronic bronchitis. If it's the very edge of the lung that's affected, the alveoli, those gas exchanging sacs we were chatting about just a minute ago, then the name for that, strictly speaking, is emphysema. And it's only when the bit in the middle is affected, not the big airways, not the sacs, so the smaller air tubes, it's when those are affected that we say someone has COPD. And the only way to know if someone has COPD is to do a breathing test called spirometry. So that's a little bit about the terminology of COPD, chronic bronchitis, and emphysema. Two other terms that we might need to think about in relation to COPD are asthma and bronchiectasis. And the confusion arises here because actually there aren't very many symptoms of lung disease. The main symptoms, cough, phlegm, breathlessness. And cough and breathlessness can be features of COPD, can be features of asthma, can be features of bronchiectasis. We just talked about COPD being the end result of someone who is genetically susceptible, being exposed to something harmful, like cigarette smoke, and that resulting in a narrowing of the airways. Well, bronchiectasis is almost the reverse problem, not airways that are too small, but airways that are too big. And these airways which are too big and are inflamed also produce lots of mucus. That mucus is difficult to clear. And so patients living with bronchiectasis have a lot of cough and phlegm and are prone to picking up chest infections called exacerbations. Asthma can look like COPD, indeed some people sometimes have a mix of the two, but fundamentally it's different. Remember, COPD is the body reacting to something which was potentially harmful. Asthma often is an allergic diagnosis. An allergy is the body overreacting to something which is generally harmless. I'm allergic to cats. If I see a cat in the room, I'm sneezing and I'm wheezy, but that cat is not intrinsically harmful to me. I have an allergy to something in the cat fur called FeLD1. So asthma and COPD can look the same. Fundamentally, they're very different. Sometimes we're asked if lung conditions like COPD run in families, and that's actually an interesting question. We've talked before about the idea that just being exposed to something is not enough in general to develop a lung condition like COPD. There has to be something about you, about your genes. And we do have an example of that. It has a long name. It's called alpha-1 antitrypsin deficiency. And alpha-1 antitrypsin deficiency is responsible only for about 1% of COPD in the UK, but it is an example of a cause of COPD that does run in families. And the things that alert us to alpha-1 antitrypsin are unusually severe COPD at an unusually early age, or COPD that really does run in the family very, very clearly. And if we see that, it is important to do some testing for alpha-1 antitrypsin because it might affect other family members too. Let's talk briefly about something called comorbidity. It's a long term, but essentially it means that people have more than one medical condition at the same time. And that's actually quite common in people living with COPD and other respiratory conditions. If you have COPD, the fact that your lungs have been affected puts you at greater risk, slightly, but greater risk, of things like heart attacks and strokes. And so that means if you're living with COPD, your attention to your risk factors for these other things like blood pressure, cholesterol, exercise is even more important than it will be for somebody else. And that's why pulmonary rehabilitation is such a good treatment. It's exercise and education, it's good for your lungs, but it's not just good for your lungs, it's good for your cardiovascular system and indeed your mental health too. I've been asked to think about what the best and worst things you could do are if you're living with COPD. And you know, I don't know how to answer that. I've got so many things that I could say. I'm going to emphasise, of course, about smoking cessation, first and foremost, but many of you have done that already. Secondly, I'm going to emphasise the value of pulmonary rehab as that exercise and education class, not only making you fitter, but more knowledgeable about your condition. I'm going to emphasise the importance of working with your clinician to find an inhaler regime that works for you, that you're comfortable with and that you can use properly. And I'm going to emphasise, lastly, the importance of making a plan in advance of what you would do if you were going to get an exacerbation, an infection. So that if it does happen, and I hope it doesn't, but if it does, you know exactly what to do. You know who to call, you know what's going to happen. So I think that's how I'm going to end.